Yes, I must say I love them, but not in the clinic. But of course, I will have to do some examinations to them. And generally, the technique of examination is the same. It's not much different, just the size of the patient is different, that's all. And a little bit, of course, of the cause of the hypertension in the children is usually different than in adults, because in adults what we do generally have it's an atherosclerosis and renovascular hypertension caused by atherosclerotic lesions in renal arteries and by hypoperfusion of the kidney. And in children, we do have hypoperfusion of the kidney, but it is not atherosclerosis, so we do look for other diseases. So I hope I will know how to use this. This is this way, no, this is not right. This is back. So, no, this is another, this one, yes? Okay, so this is one, the bigger one. So when we start the examination, it doesn't depend on the child of another, we start from anatomy. And we must remember that both kidneys, if they are both kidneys, of course, because we must remember that we may not have both kidneys. And we may have one kidney, we may have agenesia of the kidney, we may have hypoplasia of the kidney in the children. So we starting from looking for those kidneys. In a retroperitoneal space, we must remember that the approach is from the abdomen, because from the back is not very easy, but we do it sometimes if we do have a lot of gas in the abdomen, so we must sometimes approach from the back, but generally it's from the front of the abdomen and from those lateral parts of the abdomen. I hope I know how to have a light. Do I have a light here?
Yes.
Yes, and this is which one? Yeah. Oh, this one, okay. I'm sorry I didn't train before. So I have to train. So two kidneys lying in the retroperitoneal space, that is a general view what we have, and generally we do have two renal arteries. And of course we do have multiple variants. I believe you all know about it. They are not so difficult to remember, but when you start ultrasonography, it's very difficult to find it because you are expecting a normal view, and if you don't have a normal view, you have to think. So we always start Doppler ultrasound from the aorta, and we must check the aorta from the longitudinal approach and cross-section approach to see the size, to see the wall. And if in adult patient we do look for atherosclerosis, we do look for aneurysm. So in young patients, no. In young patients we do look for generally for a proper aorta, but sometimes we are surprised by the changes in the wall, and like you see it here, it's a Takayasu disease. So we may find it. And we may find, of course, some narrowings like in mid-aortic syndrome. So the first anatomy is very important and must be checked, both longitudinal approach and cross-section approach. And then we measure a flow. And the flow must be measured in different parts because it depends on of course, on the size and if we have narrowing or not, because we must check if this narrowing is important for the flow we do have in the branches. If we do have the narrowing of the aorta in a young child as abdominal mid-aortic syndrome high in the level just below the diaphragm, we do have the change in intrarenal flow like we have in coarctation, as you know. So we do have the flow like after stenosis, and we may have the proper renal arteries, but the flow post-stenotic. That is the point we must check first. the whole abdominal aorta, and we should do it really very carefully to know what is the beginning of our study. And then we are looking for the origins of the renal arteries, and the origins of the renal arteries generally are about at the level of lumbar 1, lumbar 2. This is the most common place for the origin of the right and the left renal arteries, but of course we may have multiple renal arteries. They may origin from the diaphragm to the iliac artery, so we may have up to 6 even sometimes, because the most I have seen in my life, there are 6 renal arteries to the 1 kidney, from the diaphragm to the exterior iliac artery. So it is very difficult to do it in ultrasound, but you must know that you may expect it. So generally you have 2 renal arteries on the level of the lumbar 1. That is the most important. And the first one, we do have a cross section that I will show you while we will be checking our patients. I will show that we are first looking for the left kidney vein, and below the left kidney vein generally we have the origin of the 2 renal arteries. The left one is going just directly to the bottom, to the back of the patient, and the right one most often goes a little bit high up to the abdomen frontal wall, about 60 degrees, something like this most often, and then turns to the back. And of course measurements can be done both from the central view from the abdomen, and then from the lateral sides. Generally from the lateral side, when we go through the flank, we do have the better measurements because the angle of the measurement is much smaller. From the central view we have about 60 degrees, but from the flank view we have about 20, even sometimes 5 degrees, so the measurement is more perfect, but sometimes difficult to obtain. Sometimes we do see multiple renal arteries if they go each by one as a pair of the renal arteries. As you see here, 2 right renal arteries, 2 left renal arteries. It happens. And when it happens this way, we can see it at the beginning of our examination. But when they are going, they originate from the other part of the aorta, we never look at them this way. We should always check it from the lateral point of view, looking what is going on from the upper and lower part of the kidney, how they go, how the renal arteries goes, if they go to the one or they go to the different parts of the aorta. This is the only way. From this cross section, we may not see it. So if you don't see it this way, just always check it from the lateral side. What are the criteria for assessing the significance of the stenosis? That is very important. These criteria, I must say just at the beginning, for the adults, not for the children. First of all, when we have the children, this is, you see, 1.82 meters in the renal artery, but children do have higher speed in the aorta. So adults do have the speed in the aorta from 50 centimeters per second up to 80, 90 centimeters per second. This is a general speed of the adult's aorta, but not for the children. So this is peak systolic and diastolic. This is not very, it doesn't acquire to children. What is important when you measure the velocity in children, it's end systolic velocity. It's very important. As more higher is end systolic velocity, we may be more convinced about the diagnosis of the stenosis. So what is general basic is a renal aortic ratio. If the renal aortic ratio is higher than 3 or higher or equal or higher than 3.5, it is the real diagnosis of the stenosis. Sometimes it's hard to obtain because we cannot reach ostium, we cannot reach the proper, we cannot get a proper measurement. So very often I do look really about the end systolic velocity. More higher end systolic velocity, more important is the diagnosis of renal artery stenosis. We do need to have a presence of turbulence and aliasing. That is important for the stenosis, especially when the stenosis is higher than 80%. That happens in children, because in children, when we have a stenosis and renovascular hypertension, we do have high-grade stenosis. So this is very important, and we should try to visualize the whole artery. If we cannot do it properly, we must be a little bit careful in what we are telling about the patient. And in intrarenal branches, what is very important is acceleration time. When the acceleration time is higher than 50 milliseconds, we may expect the stenosis. Acceleration, it's not what we are using very often. The time is basic. But what is important is the presence of what we call pulsus tardus. So that means that the flow rises slower, but also goes down slower. So there is not much difference between the peak systolic and diastolic, but this is only in intrarenal branches. If you have the flow like this, you must remember that this is the flow like this. This is the slow acceleration, slow going down. So this is the pulsus tardus, and this is why you can think about the significant stenosis. Of course, you must remember about the proper measurement. So the angle, I'm sorry, this is not the word. The angle is very important. The angle must be lower than 60 degrees. This is the basic for all of us who do ultrasound. But if we in renal arteries, it is not, of course, this is show the carotid artery, but sometimes it's difficult to get, especially in obese patients, it's difficult to get a good angle. So we must be very careful about the values, and we should think about more the morphology when we assess stenosis. When we do not have a proper angle, just think about morphology, less than about the values of the speed. So coming to this children, so look at this. When we have renal artery stenosis, look at the etiology. Over 80% is atherosclerotic lesions. So this is not the populations for children and young adolescents. So our populations, children, young adolescents, it's quite small from this, as you see. It's very small, it's less than 20%, and most of this, 80% of this is fibromuscular dysplasia, and the other causes are very, very, very rare. And so generally we'll think about fibromuscular dysplasia, but I will skip the atherosclerosis, okay, if you don't mind, because it's not for you. However, it's very interesting and important because we do really have a lot of these patients with problems, and as you see, we sometimes have recurrent stenosis and very difficult problems to solve with these patients, sometimes clinical. But when we look at the young patients, we'll have to think about first fibromuscular dysplasia. And what is most often, this is multifocal fibromuscular dysplasia, because this is over 80% of the fibromuscular dysplasia. So, but when you have a young child, a patient with a real high hypertension, what do you expect? This or this? Multifocal or unifocal? No.
Uni.
When you have a patient with a real hypertension and with a real renovascular hypertension, you must expect unifocal. Unifocal and in the trunk, and especially in the beginning of the trunk, because the multifocal FMD, it's a very can be very nicely visualized, as you see here, and it's a very attractive as a picture, but generally does not give a very significant lesions. It looks really nice, but the flow generally is we do have enough flow to the kidney to avoid renovascular hypertension. But in unifocal FMD, and what you should also remember that the unifocal FMD is most often present in boys than in girls, because fibromescular dysplasia is generally regarded as a disease of women. But this unifocal stenosis with a high hypertension are present in boys, in young boys. And we do see, so if you have a young boy with a high hypertension, look for unifocal stenosis of the trunk. When you have a young woman just with a moderate hypertension, just think about multifocal FMD, okay? It may look very strange, but that is what we see from our patients. Of course, we need to remember that this is not inflammatory idiopathic vascular disease. So, for women, for women who are over lower than 30 or over 30, when we are looking, this is our general group for searching for fibromuscular dysplasia, but these women will have multifocal dysplasia, but drug-resistant hypertension, accelerated malignant hypertension in the young patient, there will be boys with a unifocal stenosis. So that is for the young ones, And if we have a boy, of course, or a girl with drug-resistant hypertension, abdominal root, and small kidney on the one side, so we should really be very careful of screening for this unifocal high-grade stenosis. But being a little bit strange for you, I will show you a patient, female patient, 20-year-old, with a drug-resistant hypertension, abdominal root, whom we made a Doppler ultrasound, and as you see, there is a stenosis, high-grade stenosis. I was not able to measure the peak systolic velocity because it was so high, but the end systolic velocity you see here is over 2 meters per second, so it's extremely high. And you see turbulence. The kidney was smaller than the left kidney was smaller than the right one. And in the intrarenal arteries, we do have a pulsus tardus with acceleration time over 80 seconds. So we decided to do a computer tomography to check it, and what do we see? It's a unifocal stenosis of the trunk. And generally, when we do have a stenosis, we expect turbulence behind the stenosis. But when we have such a high-grade stenosis, look at the artery. This stenosis should be somewhere here, but we do have turbulence in the whole arteries because the stenosis is so big that the flow goes back, and that is causing this turbulence. So we have one turbulence after stenosis, just because of rotation, and before stenosis, just of the flow going back to the aorta. So in the whole renal artery, we do have turbulence. But what is the most while you were most happy with this, that I'm sorry for these pixels, but we couldn't get better pictures from this, making it big, that we could make a very, very nice angioplasty. And that is what I want to also to tell you, that generally in fibromuscular dysplasia, we do angioplasty, we do not stent. When in atherosclerotic lesions, we do stent, because it's recurrent. In a fibromuscular dysplasia, we do not stent. We stent only when we have complications. And the most important complications we generally have in these kinds of stenosis, it's dissection. And if we have dissection, we must stent. So this is the rule for the treatment, intravascular treatment of the renal artery stenosis in the young ones, and especially in the fibromuscular dysplasia. Another patient, and you see the age is different. She's older. She's 43, but also drug-resistant hypertension, abdominal brute, but hypertension almost crazy. She had almost 220 on 100 milliliters of G. So crazy hypertension. She was very in the brute in the abdomen. This is very rare. We can see in ultrasound what you see here. So we can see the string of beads in ultrasound. That is very rare, but we can see it sometimes. So when we see this string of beads here, so we know that we have fibromuscular dysplasia. There's no other entity that can give this kind of presentation. And what was the most important, we had to measure the speed, and this time we have to measure the speed, because when you see all these pearls here, you never know where the most important stenosis is. So you have to measure along the whole trunk. And here in the distal part of the trunk, we have a really significant stenosis with a very high and diastolic velocity. And this is in both kidneys. In the end part of the trunk, in both kidneys, we do have a really high diastolic velocity with a high systolic, unmeasurable systolic velocity. And also in both kidneys, right and left, we have a pulsus status. So what we find in CT, we can find a string of beads and a very tight stenosis, not only one but two tight stenosis on the right renal arteries, and the left one. What was strange for us, but this is the presentation that happens sometimes, because generally we are expecting that when we have multifocal stenosis, we do have only multifocal stenosis. And look, this is multifocal stenosis. On the other artery is unifocal stenosis, unifocal tight stenosis here. That happens, but we must call it, because of this string of pearls, multifocal. Just maybe this multifocal didn't go this way exactly then in the left artery, then in the right one artery, and made only one beat, one just stenosis. But we do have stenosis of both renal arteries, so bilateral renal artery stenosis, and look at the changes in the splenic artery, changes in the trunk. Fortunately, the other arteries to the intestines are fine. So, because we also should remember that fibromuscular dysplasia, it's not only renal arteries. When we think about hypertension and kidney, we think about renal arteries, but we do have fibromuscular dysplasia in whole arterial bed, so both in whole abdominal arteries, in visceral arteries, in the carotid arteries, and also in the base of the brain, also in a Willis circle, we may have stenosis. However, most often with fibromuscular dysplasia, we do have aneurysm, maybe not big, small ones, but we do have in a 13-14% of the patients, we do have aneurysm. So for fibromuscular dysplasia, we do screen whole patient. Please remember about it. With a patient with fibromuscular dysplasia and hypertension, we must screen the whole patient. The head, the carotid arteries, limb ones, and the whole abdomen. We may have changes in the whole arterial system. Other rare causes, not concerning only fibromuscular dysplasia, are both stenotic and non-stenotic. And of course, we have also focal, mostly focal lesion that goes with neurofibromatosis, Williams-Barré syndrome, Alagille syndrome, idiopathic mid-aortic syndrome, because mid-aortic syndrome we can have with fibromuscular dysplasia, with Takayasu, and idiopathic. So, because mid-aortic syndrome is just a visualization of the abdominal aorta, not the cause. Mid-aortic syndrome is just the narrowing of the abdominal aorta, but it may happen in many diseases. And other stenotic lesions, it's a dissection that is rare, but it happens. Both may happen altogether, just only isolated renal artery dissection, or goes with, or may go with dissection of the aorta, inflammatory disease like arteritis, and of course very rare and very difficult to recognize in children, segmental arterial medullosis, because it's in children, we do not have a clear clinic. So we do see that something happened in the renal artery. Generally, it looks like dissection, but it may be segmental arterial medullosis. So it's, I must tell you that it happens, but it is very difficult to be named exactly this way, because we may see only dissection, or we may see thrombosis. So both in a segmental arterial medullosis, the visage of this may be dissection and thrombosis. But it will be very difficult to say that this is segmental medullosis. And of course, vascular malformation like aneurysm, arteriovenous fistulas, that may lead also to hypertension in children. And of course in venous, so this is how it looks like as it's presented in the renal arteries and in kidneys. So vascular malformation are generally in the kidney, mostly focal lesions are mostly in the branch, in the trunks of the renal arteries. So that's what you know much better than me, but you must remember is that the angiographic aspect, what we see as radiologists of the renal artery stenosis in these syndromes, are very much like with focal FMD. So we cannot discuss about these syndromes without a clinic. So we are only auxiliary to you. You are treating the patients, and we do look for stenosis, but we are not the one to make diagnosis. We can only say if we have stenosis or we do not have stenosis, but as radiologists, we just leave you the diagnosis. What we can diagnose sometimes is Takayasu arteritis, because we do see the thickening of intima media. And if we have a thickening of intima media in the young patients, it's only arteritis. It's no chance for the other disease. It doesn't happen it doesn't commonly happen in the renal part of aorta, because influence mostly aorta and the origins of the arteries. It's aortic arch and the left carotid artery and the left subclavian artery. This is mostly the most common localization of the Takayasu arteritis, but if we have it in abdominal aorta, mostly renal arteries are involved. And it's nicely visible if we have it, because we have the thickening of intima media in the aorta. We do have really stenosis in the origins of the renal arteries. Sometimes significant, sometimes not, because that does not have to be significant, but we see, sorry, but these are so close that I miss it. And this is the best visible especially in young ones, in magnetic resonance visualizations beautifully. And we are trying not to use computed tomography too much for this patient, but sometimes it's important when you have problems with approaching or some problems with the extrarenal arteries. The value of the computed tomography, it's a little bit higher for the vessels than the magnetic resonance, because the spatial resolution is higher. And we may have the whole screening of the whole body in the same short time. For the magnetic resonance, we need many approaches. It's not so. It's very dependent on the breathing. That is very difficult in children, and we must do sedation. So sometimes it's much more easy and convenient to make a tomography. So please remember about it, that we are trying to do not use the X-ray for the young ones, but sometimes it's just the only way to have a good picture. And in Doppler ultrasound, we just only check if these stenoses are significant or not significant. So as you hear, one is significant, one is not significant. So, and there is a point with also with the way we treat these children and the young women, because we cannot make any intervention, especially intravascular intervention, in the moment when inflammation is clinically present. So we must treat the patient, just lower the old inflammation features, and then we can do angioplasty. We never in Takayasu do stenting, because that causes just almost immediate stenosis. So we do angioplasty and it works. Of course, the most efficient is surgery, but sometimes we are trying to avoid surgery until patient grows up. When the patient grows up and obtains its final size, we can do operation, and that is the best for the patient and the best for the kidney. Isolated renal artery dissection, it's a very rare disease. We are not very sure about the clinical background of this, but when it happens, it has very clinically, it's very active, and we may have pain, at a really very big pain, and it's significant because infarction is really painful. Sorry. And the changes of the flow do not depend exactly on the stenosis, because the changes of the flow depend on the many lumens that are created in this dissection, because this is the false and true lumen are crossing each other, and as you see, sometimes presenting as even at the end of the artery, they present as aneurysm. So this turbulent flow through the dissection causes exacerbation of the renal the renal system, and we are looking about for the flow in the ultrasound, but maybe we may not have a real significant stenosis, as you hear a patient, not an adult one, with a dissection. It's a strange how this artery looks like, because in the adult patient, this artery that looks very small, but it's not small, flows only half of the artery. The half of the artery doesn't flow. And we do have turbulence, but not so high, and the flow, it's not very, there's no high speed of this flow, but we do have hypertension, and we do have pain in the left flank. And that's what we do have in the computer tomography. As you see, there are two lumens, true lumen, false lumen with some. That's why you haven't seen here a flow here, because we do have thrombosis of the false lumen, and we do have we do not have flow in the parenchyma of the left kidney. So this is what we see properly in the tomography. What we can see in the ultrasound, it's only not proper flow in the kidney. We do have the upper lobe without a good perfusion. So from the Doppler ultrasound, we cannot make a diagnosis, unfortunately. So you must remember that this is sometimes very difficult, but what we may suspect is that there is something wrong in the left renal arteries, because the flow is not through the whole lumen. And this is the dissection is the only one who does make this picture of this kind of the picture, but also thrombosis may do this. But they generally go together, thrombosis and dissection. What we have with a complication following aortic dissection, they are very rare and not often happens to the children, but in young adolescents with hypertension, they do happen. We do have dissections, especially in young men, 20 something, that happens. And also they may be followed with malperfusion of the kidney. There are many mechanisms of the malperfusion of the kidney. It depends on how the false and true lumen do comply together. But we may have a static dynamic occlusion, ostial tear, and of course the full occlusion with thrombosis. And sometimes we do have dissection. One artery origins from the false lumen, one from the true lumen. Generally, please remember that the false lumen is mostly on the left side, and the true lumen is mostly on the right side. It's the most often, but doesn't have to be true always. So when there is a good communication between two channels, we may have a very good flow to the kidneys, and we may have no even hypertension. But when there is no good communication, when there is a thrombosis, there are tears in the ostiums, and when we have thrombosis going into the trunk, we may have severe hypertension. And the problem is also that generally we do have hypertension before aortic dissection, and with this malperfusion we have even more hypertension in the patients with this bad flow. So this is a dissection that is quite calm, and with a good flow between two channels, looks nice, and the flow in both channels looks good, and the flow in both kidneys looks good. This patient does not have hypertension. But when we have and see, this is with if you see only kidneys, You would never say it's a patient with dissection and such a terrible disease, and both left and right kidney looks fine. But when we have dissections that goes with thrombosis, it just looks much worse. When we have non-stenotic lesions with rare causes of renovascular hypertension, malformations and thrombotic complications. So I will just shortly go with malformations, arteriovenous fistula, are different. They are mostly acquired and mostly after percutaneous renal biopsy. That is the most often cause of the arteriovenous fistula. Of course, trauma, surgery, malignancy, but sometimes it happens during congenital. We don't know why. We expect most often that this is, I'm sorry for this, but these are very close. Maybe congenital, maybe in the course of some special form of fibromuscular dysplasia. We do have hypertension because of a short circuit of the blood and because of a local renal ischemia behind the fistula and secondary activation of the renin-angiotensin system. In a Doppler, it's very nicely easy to find, so we may see this flow, mechanical as we called it, flow, going back and go further, going straight and back with much more elevated flow in the renal vein. What is nice in these fistulas is that we may treat them at this moment easily through the interventional radiology, just coiling them, because this is the most often the best way to close them, just to put some coils and just to close this circuit, and with a very good result. Renal artery aneurysm, we do think that it is a very strange that we do have a proper renal arteries and we do have the signs of the renal artery stenosis. Why it happens? It happens just because the bigger is a renal artery aneurysm, the more blood goes into this with the high of the flow, and at the end diastolic, I'm trying to just too close. When it goes out, it goes back. So it's like a tight stenosis. So the blood goes into the aneurysm, and then going out of the aneurysm goes the other way than the blood going into the trunk. So it creates the false turbulence, the false circuit, and it creates the false decreased distal artery perfusion. Because this is false. We do not have this malperfusion, but because of the turbulence, the kidney thinks it has malperfusion, and that is the reason that we may have the signs of the renovascular hypertension, and look at the patient with this renal aneurysm, look at the pulsus tardus in the kidney, and the renal artery was absolutely non-stenotic. We just had the renal aneurysm, and after it was covered with a cover stent, and it was closed, the flow in the kidney is perfect. So this is the reason why we could treat these patients easy, effectively, and we treat not only aneurysm but also hypertension. What about thrombosis? I will not take too much because this is not much children's disease. It's much more happens often with adult patients, but with a dehydrated patients, it may happen even with children, because nausea, vomiting, fever, hypertension may lead to the thrombosis. And this is treatment should be decided on the case-by-case basis. It's very difficult, it's more conventional. So this thrombosis is adult patient, but you see this is usually goes with the hypertension and with the pain and with the increase of creatinine. So one final remark is that there's always reason to do ultrasound. However, we often may not be sure what is the reason of what we see, because we see and we are obliged to show you what we see, but the reason lies in your hands. So thank you very much. Do you have any questions to this presentation?